Now we've reached the final subsection of skin disorders, the miscellaneous disorders. While these couldn't be categorized into the groups already listed, they're worth remembering because most of them have certain pathognomonic findings that help you recognize them clinically. Also, a few of these are indicators of underlying disease. The first of these diseases is acanthosis nigricans, a classic example of how a skin finding can indicate underlying disease. Do you recall the skin layer affected in acanthosis nigricans? There's hyperplasia of the stratum spinosum. What should you suspect with these skin findings? Likely insulin resistance, i.e. diabetes, or a visceral malignancy. The next lesion is actinic keratosis, a small, rough, red or brown papule that's considered pre-malignant. Do not forget these are pre-malignant lesions. What lesion can derive from these small, rough, erythematous papules and plaques? This could become squamous cell carcinoma. It's thought to be associated with sun exposure. Erythema nodosum is inflammation of the subcutaneous fat, particularly on the front of the shins. There's a huge differential for what diseases have erythema nodosum as part of their presentation and include fungal infections and TB, as well as leprosy, streptococcal infections, sarcoidosis, and Crohn's disease. The next lesion is lichen planus. The skin lesion is classically and always described as pruritic, purple, and polygonal papules. Histologically, lichen planus appears with sawtooth infiltrations of lymphocytes at the dermal-epidermal junction. What virus is this lesion associated with? Hepatitis C. I like to remember that lichen planus with a P shows pruritus, purple, polygonal papules, all P's, and it's associated with hepatitis C, which also has a P in it. Now, what is this lesion? Well, it's pityriasis rosea. Though you won't likely see it, it's worth knowing because it's marked by two classic skin lesions. The first is the herald patch, usually a small patch that occurs initially and heralds the later popular eruption that occurs in a Christmas tree distribution. What do you need to do for this rash? Nothing at all. The disease requires no treatment as it will go away by itself. Finally, let's talk briefly about the common sunburn. Now, what cells die during sun exposure? UV radiation from the sun induces apoptosis in the keratinocytes in the epidermis. This effect is predominantly caused by UVB radiation. Excessive sun exposure and blistering sunburns are risks for skin cancer. Wear sunscreen. What is purple, pruritic, and presents with polygonal papules? Lichen planus. Also, it's associated with hepatitis C. Which type of UV radiation causes skin cancer? UVB. Skin cancer is an incredibly common type of cancer, and in many cases, not a life-threatening one to have. There are three main types: basal cell carcinoma, squamous cell carcinoma, and melanoma, all of which have classic appearances that you should be familiar with for your boards. Basal cell carcinoma occurs commonly in sun-exposed areas. They are locally aggressive but tend not to metastasize. Basal cell carcinoma is the most common skin cancer. It will be on your boards. The classic description is central ulceration, but may also be described as pearly papules with rolled or heaped up borders that show telangiectasias. Once you see it, you'll never miss it. Don't confuse this nodule with central ulceration with a cyst. How else could this be described? Well, a non-healing ulcer, perhaps, or a scaling plaque. What should you suspect if you do a punch biopsy of the lesion? Palisading nuclei. Squamous cell carcinoma is a skin cancer that is thought to arise from another skin lesion that we just discussed. Can you remember which one? Very good. Actinic keratosis. Squamous cell carcinoma is usually expected on the hands and face and may have serious local invasion, but rarely will invade past the basement membrane. On gross appearance, the lesion appears red and may be ulcerated. Histologically, the key finding is a keratin pearl. There are 3 associations of squamous cell carcinoma that you should know. It's associated with sunlight exposure and commonly appears in the face, lower lip, ears, and hands. It's also associated with immunosuppression, arsenic exposure, and prior chronic draining sinus tracts. What bacterial genus typically causes chronic draining sinus tracts that discharge sulfur granules? Very good, it's Actinomyces. One variant to be aware of is the keratoacanthoma. This grows very rapidly and then regresses over the course of a few months. The final type of skin cancer is melanoma. This one's serious. And why? Well, because unlike squamous cell carcinoma and basal cell carcinoma, melanoma can metastasize. The classic question is what aspect of the tumor affects its likelihood to metastasize? And the answer, no matter how it's phrased, is its depth. This is known to surgeons as the Breslow thickness. Well, this kind of makes sense, so it's easy to remember. The deeper a skin cancer goes, the worse the prognosis. The lesion itself is described with the ABCDE memory aid. A is for asymmetry, B is for irregular border, C is for more than one color, D is for diameter greater than a pencil eraser, and E for evolution over time. Risk factors for melanoma include fair skin and increased exposure to sunlight, as well as a prior history of a dysplastic nevus, as this can be a precursor lesion. There is also a tumor marker that can be used as a staining technique if there is a concern for melanoma. Do you remember what it is from the path section? That would be S100. Just think of S as standing for skin. S100 is normally present in neural crest cell derivatives. Can you name a few? Schwann cells, melanocytes, and glial cells. So you may use S100 as a schwannoma marker as well. Of course, if the melanoma is on the skin, it is usually easier to know it's a melanoma. But remember, the melanoma has many different forms. The ABCDE mnemonic we discussed is best for the common type of melanoma, which is called superficial spreading melanoma. But there are many other types, including nodular and amelanotic, or colorless. Also, 20% of cases with metastatic melanoma present without a primary melanoma on the skin, presumably because it was small and defeated by the immune system already. If you do get a question about metastatic melanoma, remember that melanoma is a mean cancer. It does not follow any rules. It can quite literally go anywhere in your body, from your gut, to your liver, to your bone, to your brain, to your eye. If you ever get a micrograph of a MET, though, it's pretty easy to figure out. If it's a melanoma, as melanoma should be, it'll be uniformly darkly pigmented in any picture you would see on step 1. What should you do for these patients? You should excise it with wide margins. What if you have a patient with METs? Check the patient for the BRAF V600E mutation and consider giving vemurafenib. Now what's vemurafenib? It's a BRAF kinase inhibitor. Flash quiz. What looks like palisading nuclei on punch biopsy? Basal cell carcinoma. Let's take a look at a board-style question. A 45-year-old woman comes to a dermatology clinic because of painful, blistering lesions on her torso, extremities, and oral mucosa. The blisters are flaccid and break easily with the application of pressure. This patient's condition is the result of production of autoantibodies against which of the following labeled skin layers? The answer is C, the epidermis layer. This patient has pemphigus vulgaris, an autoimmune disorder in which pathogenic antibodies are directed against a cell-cell adhesion protein, the desmoglein 3, which is expressed by the keratinocytes of the epidermis. These desmoglians are also known as the macula adherens and are located between keratinocytes all over the epidermis. Therefore, the destruction of desmoglein leads to an intraepidermal acantholysis with sparing of the basal layer. Physical exam typically shows flaccid epidermal bulla that easily slough off, leaving large, denuded areas of skin, classically known as the Nikolsky sign. Treatment is usually steroids. Alright, well that finishes off the dermatology section. I'll see you next time.